Margaret was 74 years old. She had a bad back. Had it for years. Her doctor told her spinal fusion surgery was the answer. She would be in and out in a few days, back on her feet in a few weeks. She went in for the surgery. She never walked again. Not because the surgeon made a mistake, not because something went wrong in the operating room, but because nobody, not the surgeon, not the hospital, not the consent form, told Margaret the truth about what surgery does to a 74-year-old body. And here's what breaks my heart about this. Margaret's story is not rare. Hundreds of thousands of seniors every single year are pushed into surgeries that the science, the actual peer-reviewed, published in top journals science, says they should never have agreed to. Today I'm going to give you the conversation Margaret never got. We are counting down the 5 most dangerous surgeries for seniors, operations that carry risks so severe in older adults that many of the world's top geriatric surgeons now openly question whether they should be offered at all in certain patients. Stay until number 1, because number 1 might already be scheduled for someone you love. Why surgery kills seniors. That it wouldn't kill at 40, high-risk surgery elderly. Before I tell you the 5 surgeries, I need you to understand one thing, because without this, the numbers I'm about to share won't fully hit you the way they should. When a 40-year-old goes under general anesthesia and has a major operation, their body has enormous reserves. Their heart can handle it. Their lungs recover quickly. Their immune system fights infection. Their brain bounces back from the anesthesia fog. Now imagine that same surgery on a body that has been running for 75 years. The kidneys are filtering at maybe 60% of what they once could. The heart has less reserve. The immune system is slower. The brain, and this is the part that terrifies geriatricians, the brain is exquisitely vulnerable to the chemical assault of general anesthesia. One major study from Yale found that nearly 1 in 7 older adults dies within a year of undergoing major surgery. 1 in 7. And the more frail the patient, the worse it gets. Frail seniors, and frailty is a medical term, not an insult, face surgical death rates 5 to 8 times higher than healthier patients the same age. Hold on to that number, because you're about to see it show up again and again. Let's start the countdown. Surgery. 5. Spinal fusion, the surgery that traps seniors in a cycle of more surgery. So here's a question. Raise your hand if you know someone over 65 who has been told they need spine surgery. I'd bet a lot of hands just went up. Spinal fusion is one of the most commonly performed surgeries on older adults. The pitch sounds reasonable. Your spine is degenerating. 2 vertebrae are rubbing together, causing you pain. We bolt them together. Problem solved. Except it's not that simple. Not at 70. Not even close. Here's what the surgeons don't always have time to explain. When you fuse 2 vertebrae together, the vertebrae above and below that fusion are now forced to compensate. They absorb extra stress. They start to break down faster. And in seniors, whose spines are already degenerating, that almost always means adjacent segment failure. A new problem. In a new part of the spine. And then comes the conversation you didn't expect. We may need to do another surgery. This is documented in the scientific literature. In a large-scale study of over 30,000 spinal fusion patients, those over 65 faced dramatically higher rates of major complications, blood clots, infections, respiratory failure, and cardiac events. And here's the part that should genuinely anger you. A Cochrane review, the gold standard of medical evidence, found that in elderly patients with lumbar stenosis, supervised exercise therapy and injections produced outcomes comparable to surgical fusion. Comparable, without the surgery, without the risks, without the recovery, without the possibility of a second operation. Spinal fusion in seniors often creates more problems than it solves, and the science shows non-surgical options frequently work just as well. Ask your doctor. Before spine surgery, what non-surgical alternatives exist for my specific age and frailty level? What does the evidence show for patients over 70? But spinal fusion is number 5, which means there are 4 surgeries that are even more dangerous for seniors. And the next one? It involves stopping your heart completely. Surgery 4. Open heart bypass. What they don't tell you before they stop your heart. I want you to picture a 78-year-old man, retired, loves his garden, has some chest pain, goes to his cardiologist, comes home that afternoon and tells his daughter he needs open heart bypass surgery. He's terrified. She's terrified. They agree. Because what else do you do when a doctor tells you your heart needs surgery? Here's what neither of them knew. For elderly patients without certain specific, high-risk anatomical features, multiple major studies now show that open heart bypass surgery does not extend life compared to optimal medication management. Let me say that again because it is genuinely staggering. Surgery that stops your heart, cracks open your chest, and puts you on a machine for hours, in many elderly patients, produces no survival advantage over taking the right medications. That's from a major analysis published in the New England Journal of Medicine by Weintraub et al. But here is the complication that haunts me most. It's called postoperative cognitive dysfunction, POCD, and it is exactly what it sounds like. After open heart surgery under general anesthesia, a significant number of seniors never quite get their mind back. Memory problems, difficulty concentrating, word-finding difficulties, personality changes. A landmark study in the New England Journal of Medicine measured cognitive function in cardiac surgery patients after their operations. At 1 week post-surgery, cognitive decline in 53% of patients. At 6 weeks, still 36%. At 6 months, 24% still showed measurable cognitive impairment. 1 in 4 cognitively impaired 6 months after surgery, for a procedure that may not have even extended their life. That is not a surgical complication. That is a surgical tragedy. Open heart bypass in elderly patients carries a 24–53% risk of cognitive decline and may offer no survival advantage over medication. Ask your doctor, can this be managed with medication and lifestyle changes instead? Am I a candidate for a less invasive stent procedure? What is my specific cognitive risk at my age? Number 3 is the surgery that surprises people the most, because it involves fighting cancer, and most people assume that fighting cancer is always the right choice. The science says something very different. Surgery number 3, aggressive cancer surgery in seniors. When the treatment is deadlier than the disease. I need to say something carefully here. This is not about not treating cancer. Cancer is serious. Cancer kills people. I know that. But I also know this. For frail elderly patients, the surgery to remove certain cancers can be more likely to kill them than the cancer itself. That is not a controversial statement. That is what the data shows. A study published in the Annals of Surgical Oncology evaluated elderly cancer patients by frailty status. Their finding, frail elderly patients undergoing major cancer surgery had a 30-day postoperative mortality rate of 16 to 20%. 16 to 20%. That means roughly 1 in 5 frail elderly patients who went into surgery for cancer did not survive the surgery itself. And the reason goes beyond frailty. It goes into the nature of cancer itself in older patients. Here's something most people don't know. Many cancers in older adults are biologically slow-moving. A prostate cancer that would have killed a 50-year-old by 60 might take 25 years to become symptomatic in a 75-year-old, meaning it may never threaten their life at all. The New England Journal of Medicine published a 12-year study comparing radical prostate surgery versus watchful waiting. After 12 years, There was no significant difference in survival between the two groups. But there was a very significant difference in quality of life. The surgery group had dramatically higher rates of urinary incontinence, sexual dysfunction, and surgical complications. There is a term used in oncology, competing risks. It simply means, will this cancer actually kill you before something else does? In an 80-year-old with a slow-growing tumor and 3 other serious health conditions, the answer is often no. But nobody explained that to the family who agreed to the surgery. Cancer surgery in frail seniors carries up to 20% 30-day mortality. Many slow-growing cancers in elderly patients pose less risk than the surgery to remove them. Ask your doctor, what is my frailty score? What is the actual likelihood this specific cancer will affect my quality or length of life, given my other health conditions? What does watchful waiting look like in my case? We're at number 2 now, and this one kills faster than any surgery on this list. It happens in the abdomen. It's often presented as urgent, and the death rate in seniors is something that most families never see coming. Surgery number 2, major bowel surgery in the elderly. The death rate. Nobody talks about your father is 82. He's in the emergency room. He has bowel obstruction. The surgeon comes in, calm and professional, and explains they need to remove a section of his colon immediately. You sign the consent form. Of course you do. What choice is there? Here is what the consent form does not tell you. In patients over 80, emergency colon surgery carries a 30-day mortality rate of up to 26%. 26%. More than 1 in 4 elderly patients over 80 who underwent emergency bowel surgery did not survive the first month. And if they do survive the surgery itself, the complications often begin. The bowel is a contaminated surgical field. Infection rates are high. Post-operative ileus, where the bowel simply refuses to start working again after surgery, is common and dangerous in the elderly. And then there is anastomotic leak. When the rejoined sections of bowel fail to seal, bacteria flood the abdominal cavity. When this happens in an older patient, it is frequently fatal. But there is one complication I want to spend a moment on, because families almost never see it coming. Post-operative delirium. After major abdominal surgery, 30 to 50% of elderly patients develop acute confusion, disorientation, agitation, hallucinations. And this is not just a temporary fog that lifts when they go home. Research published in JAMA Internal Medicine found that post-operative delirium in elderly patients is associated with a 2-fold increase in 1-year mortality and a significantly increased risk of permanent cognitive decline. You bring your father in for bowel surgery. You bring home a different man. That is the reality for too many families. Bowel surgery in over 80s carries 26% 30-day mortality. Post-operative delirium affects 30 to 50% of elderly patients and doubles 1-year mortality risk. Ask your doctor, before emergency bowel surgery, is there a temporary stenting or diversion option that avoids full resection? Has a geriatrician assessed my parents' frailty level? What is the realistic survival and quality of life outcome? Number 1 is the surgery I debate most with my colleagues. It's the one that is almost always described as life-saving, and sometimes it is. But for frail elderly patients, the science shows that the surgery intended to save their life is more likely to end it. And it's being performed on seniors right now, today, perhaps in a hospital near you. Surgery, number 1, the deadliest, elective AA repair in frail seniors, most dangerous surgery elderly. A 79-year-old woman, frail, heart disease, reduced kidney function. She goes for a routine scan. The radiologist finds it. A 5.8 centimeter bulge in her aorta, the main artery of her abdomen. An abdominal aortic aneurysm. Her vascular surgeon explains that if this ruptures, She will almost certainly die. He recommends immediate surgical repair. She is terrified. Her family is terrified. They agree. She dies on the operating table. And here is the terrible irony. Her annual risk of that aneurysm rupturing was approximately 3%. 3% per year. The surgical mortality risk for a frail elderly woman with her health profile? 15%. In the first 30 days alone. The surgery meant to save her from a 3% annual risk. Carried 5 times that risk in the operating room. Let me be absolutely precise here, because I want you to understand this is not about the surgery being bad. In the right patient, a fit, non-frail patient with a large, rapidly growing aneurysm, a repair can absolutely be the correct choice. But in a frail, elderly patient? The European Society for Vascular Surgery guidelines now explicitly state that repair in patients with a life expectancy under 2 years offers 0 survival benefit. None. The surgery offers no advantage whatsoever. And yet, frail elderly patients with short aneurysms and limited life expectancy are still being referred for surgical repair in hospitals across the world. Right now. Why? Sometimes because the surgeon genuinely believes it's the right call, sometimes because the risk was not explained properly, and sometimes, and this is the hard truth, because the system does not have a good process for asking, should we actually be doing this? AAA surgery in frail elderly patients can carry 15% plus 30-day mortality, 5 times higher than the annual aneurysm rupture risk for many of these patients. Ask your doctor, what is my frailty score on the clinical frailty scale? What is the annual rupture risk of this specific aneurysm at its current size? What is my surgical mortality risk given my exact health profile? Is EVAR, minimally invasive repair, an option instead? What does doing nothing look like? How seniors can protect themselves from dangerous surgery, your action plan. Okay, here's the good news, and there is genuinely good news. You now know more than most patients going into these conversations. That means you have power, real power. Before any major surgery, every senior should do 3 things. First, demand a frailty assessment. Ask your doctor to score you on the clinical frailty scale. It takes 5 minutes. It predicts surgical outcomes better than almost any other measurement. If your hospital doesn't do it routinely, ask anyway. Insist on it. Second, request a geriatrician consultation. A geriatrician is a doctor who specializes in the care of older adults. Studies show that geriatrician involvement before major surgery in seniors reduces 30-day mortality, reduces post-operative delirium, and improves discharge outcomes. Yet fewer than 30% of elderly surgical patients see a geriatrician before going under the knife. If your hospital says they don't offer this, find one that does. Third, always ask what happens if you do nothing. This is the question that changes everything. Doctor, what actually happens if we don't do this surgery? What are my realistic outcomes with non-surgical management? If a surgeon cannot, or will not, answer that question honestly and specifically, that is your signal to get a second opinion before you sign anything. Closing, the conversation. Margaret never got seniors in surgery risk warning. Remember Margaret, the 74-year-old I told you about at the start of this video? The woman who went in for spinal fusion and never walked again? Her daughter found me after I posted a version of this talk online, and she said something I haven't been able to forget. She said, "Nobody ever asked whether Mum was too frail for surgery. Nobody ever mentioned non-surgical options. Nobody ever said the words frailty assessment. She just signed the form and went in." That's why this video exists. That's why Longevity Forge exists. Because seniors deserve the same information that the surgeons have. Because your life, and the lives of the people you love are worth an honest conversation. Share this video with every senior you know. Pin it. Save it. Send it to your mom, your dad, your neighbor who just got a surgery referral. It may be the most important thing you do for someone's health this year. If you found this valuable, subscribe to Longevity Forge. We do this every week. Real science delivered clearly for people who want to live longer and smarter. Hit the notification bell so you never miss a video. Leave a comment below. Tell me, have you or someone you love been pushed toward one of these surgeries? Your story might help someone else. I read every comment. I'll see you in the next one.